name is Victoria. I'm excited to present a topic that says the extrapyramidal side effects of antipsychotic drugs and the pharmacology of Parkinson's disease. So, have you ever think of maybe what psychotic drug is all about, or the mechanism of action, like the way they do work? So today I would like to explore more on it and put more insight on Parkinson, on antipsychotic drugs and its action. So the table of contents, we have the introduction, overview of antipsychotic drugs, mechanism of action, classification, and so on. So I would like to move on to the I would love to move on to the introduction. Antipsychotic drugs have revolutionized the treatment of psychotic disorder, especially schizophrenia, by effectively controlling hallucinations and agitation. However, their clinical use is often limited by various side effects, among which extrapyramidal significantly impact the quality of life and medication adherence in patients with psychiatric conditions. In parallel, Parkinson's disease, a, neuro, a, neurologi- a neurodegenerative disorder characterized by motor and non-motor symptoms, shares pathophysiological pathway with drug-induced extrapyramidal side effects. Notably, both conditions involve dysfunction of dopaminergic effects of antipsychotics and the pharmacological management of Parkinson's disease, essentially for clinical use and safe, effective treatments. This seminar presentation aims to provide a comprehensive overview of extrapyramidal side effects associated with antipsychotic drugs. So let's go to overview of antipsychotic drugs. Antipsychotic drugs, also known as neuroleptics, are primarily used to manage psychosis, including conditions like schizophrenia disorder and bipolar disorder. These medications are broadly classified into two categories, namely topical and atopical, which is secondary generations. So we are moving into the mechanism of action of antipsychotic drugs. Antipsychotic drugs primarily act to modulate the dopaminergic system in the brain, particularly targeting the D2 dopamine receptors. The therapeutic efficiency in treating psychotic systems such as delusion and hallucination is largely attributed to D2 receptor blockage in the mesolimbic pathway. However, this blockage is not region-specific. Antipsychotics also inhibit dopamine transmission in other dopaminergic pathways, such as the nigrostriatal pathway, which regulates voluntary motor control. This non-selective antagonism results in an imbalance between dopamine and acetylcholine, leading to experimental side effects such as drug-induced Parkinsonism, dystonia, and actisia. So we are moving on to the classification of anti-Parkinson drugs. So anti-Parkinson drugs are divided into two, which I mentioned before: atypical, which is the first generation antipsychotic drugs, and this one they were the first class of antipsychotics to be developed and are associated with a high risk of extrapyramidal side effects. Examples include hypotension, the first generation antipsychotic drugs. They are haloperidol, and fluphenazine. Low potency fourth generation antipsychotic, they are chlorpromazine and thyroxine. High potency first generation drug has a strong affinity for D2 receptor and thus a higher risk of extrapyramidal side effects, whereas low potency agents are more sedating but still pose a risk. So, and the second type of antipsychotic drugs are atypical, which is the second generation, and they are clozapine, olanzapine, risperidone, aripiprazole. These agents are often preferred due to their low risk of extrapyramidal side effects and better tolerance, although metabolic side effects such as weight gain and diabetes are concerned. So we are moving into the extrapyramidal side effects. So the definition is saying that extrapyramidal side effects refers to a group of movement disorder that results from dopamine receptor blockage in the extrapyramidal system, primarily the basal ganglia and the associated structures. These effects are commonly induced by antipsychotic medications and resemble symptoms seen in the neurological disorder like Parkinson's disease. Extrapyramidal side effects can present in various forms, including acute dystonia, Parkinsonism, and tardive dyskinesia, each has discrete clinical features and onset period. So we are moving into the pathological of extrapyramidal side effects. The extrapyramidal system is a network of brain structure, including the basal ganglia, substantia nigra, and thalamus, that regulates motor control and coordinations. Connected the substantia nigra to the stratum. So we have types of extrapyramidal side effects. We have acute dystonia, we have tardive dyskinesia, and so on. So we have the management of treatment of extrapyramidal side effects. We have dosage adjustment of drug. We have use of anticholinergic agents. We have beta blockers and benzodiazepine. So we are moving into the clinical management of Parkinson's disease. We have the clinical features is typically divided into motor and non-motor symptoms. Non-motor symptoms, motor symptoms. So it's divided into motor and non-motor symptoms. And we have the diagnosis of Parkinson's disease, which are diagnosed criteria: presence of bradykinesia plus at least one of the resting tumor. So we have the treatment goals and strategies in Parkinson's disease. While there is no cure for Parkinson's disease, treatment aims to alleviate symptoms, maintain functions, and enhance quality of life. Goals of therapy: restore dopaminergic neurotransmissions, minimize motor and non-motor symptoms. So in conclusion, in summary and conclusion, Parkinson's disease is a complex neurodigestive disorder characterized by motor and non-motor symptoms resulting from dopaminergic neuron loss. Antipsychotic drugs, while effective for psychotic conclusion, may induce extrapyramidal side effects that mimic Parkinsonism. Treatment strategy for Parkinson's disease focuses on the symptoms management with levodopa, dopamine agonist, MOAB, and COMT inhibitor, and anticholinergic advanced therapy like deep brain stimulation.
Your time is
Thank
up.
you.
Thank you. Thank you. Thank you very much. Thank you very much. That's you were not listening. You were not listening. None of you. None of you. Chai. She did a good work, and I like the content of the work. And the only issue that they how to manage time. That's the issue. But she did a good work, a nice work. When you said, did you mean neurodegenerative? But I was hearing neurodigestive.
Neurogenetics. Sorry.
Okay. You meant neurodegenerative.
Yes, sir.
Okay. All right. Thank you. Please, let's clap for her again, please. Thank you very much.
Thank you, sir.
Thank you.
I'm going to remove this photo.